Okay, so this is my introduction to the cardiovascular laboratory, and we're going to be coming back to this diagram in a little bit. But for right now, grab a pencil and some paper, and we're going to learn how to draw a heart, a legitimate heart, not just a silly heart, like what you might be drawing for Valentine's Day. Okay, so it's going to start like this. We're going to draw the ventricles. It's going to be a nice big open V, kind of rounded at the bottom. And the ventricles are split down the middle by the ventricular septum. That's the wall that separates the right ventricle from the left ventricle. And remember, we're looking into a person's chest cavity from the front. So the right side is over here. This is our right ventricle, which is actually the space inside of the heart on the right side of the ventricle. And on this side, we have the left ventricle. And these two chambers of the heart are pretty muscular. The ventricles are the ones, the parts that push the blood to all parts of the body. The right ventricle pushes the blood to the lungs, left ventricle to the systemic circulation, as you've learned about already. And these are the parts that are pretty distant away, so you have to visualize that these walls of the ventricle are going to be pretty well muscular. They're going to be well muscled. They're going to be capable of pushing blood with a powerful contraction. The right ventricle, maybe a little bit less so, because the right ventricle only has to push the blood as far as the lungs. And so the right ventricle is usually not quite as well muscled as the left ventricle is. When the ventricle contracts, the volume inside the ventricle shrinks and the pressure increases and the blood is then pushed in the next direction, which is going to be out of a tube. And these tubes that connect the ventricle to the outside world are closer to the septum. Here is the blood from the right ventricle being pushed into the pulmonary artery. And the pulmonary artery actually carries blood in this direction towards the right lung, as well as in this direction towards the left lung. Basically, we'll have a little split, and the blood is going to be moving to both lungs. Okay, and it's going to be passing through a semilunar valve, which is going to look like this. Actually, saw that in the animation that I was showing you before, which was from Wikimedia Commons. And so that's the right semilunar valve. And on the left side of the heart, we'll have another tube, and it's going to be coming out. And it's going to be making a little U-turn, and it's going to have a couple of branches away from the U-turn as it's making this little arch around the top. That's called the aortic arch. And the vessel itself is the aorta. Okay, and it actually bends backward towards the back of the body cavity and then down. It goes back basically down this direction and catches up on this side. It'll start coming down that direction. Right? We'll have a couple of branches. This is going to be the brachiocephalic. You'll have one branch that goes up to the head, one branch that goes out to your right arm. Then we'll have the this is the left common carotid, and then we'll have the left subclavian, which is going to go out to your left hand, left arm. Okay, so this is going to be our left arm out to the hand. This must be your left hand. This is going to be going out to your right hand. This is going to be going up to your head. These are the right and left common carotids. Head. Okay, and yeah, the blood from the left ventricle is going to be pushing blood to all parts of the body. This is just the top part of your body. There's the blood as it comes down here is going to head down to the kidneys and the intestines and the liver, and it's eventually going to split into the legs, the two femorals, and taking the blood all the way down to the legs. Okay. And when the blood returns back to the heart, basically from the top part of the body, it's going to be coming down from a tube, and from the bottom part of the body, it's going to be coming up. Basically, this is going to be the superior vena cava coming down. This is going to be the inferior vena cava coming up. And the blood is going to be passing from these venae cavae into the right atrium. This is the right atrium here, right atrium. Okay, and here's the blood that's going to be pumped. The right atrium is going to be pumping blood through the tricuspid or the right atrioventricular valve. Blood is going to be passing through this valve into the right ventricle, and then the blood is going to be pushed from the right ventricle through the right semilunar valve into the pulmonary arteries. And they're going to go out to the lungs, and the lungs are going to recharge the blood with all kinds of oxygen, and then the blood is going to be coming back. It's going to be coming back to the left atrium. And so if we were to draw the left atrium over here, maybe there's going to be a couple of tubes coming in over here. These would be the pulmonary veins. They'll be bringing back blood with a full charge of oxygen into the left atrium. And the left atrium will be pushing blood through the mitral valve, which is a bicuspid valve. And so there's the mitral valve or the left atrioventricular valve, and blood is pushed in this direction into the left ventricle, and then from the left ventricle it's going to be pushed upward into the aortic arch. We'll have to pass through another semilunar valve over here in order to get there. And that's pretty much the drawing of the heart that I wanted you to have, and you should be able to picture this pretty well. You know what would make this really good? If we added color. Okay, so we're going to be doing the standard thing, which is to color deoxygenated blood, basically blood that's returning back to the heart from the systemic circuit. We're going to be coloring it blue, okay? Light shade of blue. So this is blue blood coming back in this direction. Blood is coming back. This deoxygenated blood is going to be coming back. It's going to be passing out to the right atrium. This blood is going to be pushed out of the right atrium into the right ventricle. And when the right ventricle contracts, when the ventricle contracts, blood is actually pushed upwards through the right semilunar valve and out the pulmonary arteries to the right and left lungs. Right? And then at the lungs, we'll be basically putting oxygen into the blood, which is going to make that blood turn bright red in color. So the pulmonary veins are going to be returning blood back to the heart that's got a lot of oxygen in it. So it's got this bright red color. The left atrium fills with blood from the pulmonary veins, and then when the left atrium contracts, it's going to be pushing blood through the mitral valve into the left ventricle. And it will have the blood passing from the left ventricle. When the ventricle contracts, it's going to be contracting, pushing blood into the dorsal aorta, making this arch. Some of the blood is going to be going out to your right arm. Some is going to be going up to your head. Some is going to be going up to your left arm. The one thing that I haven't included here is the fact that we've also got coronary arteries. There's going to be a couple of arteries that are going to be coming, down the left side of the heart to supply the heart muscle itself with adequate oxygen. That will be the right coronary artery. This will be the left coronary artery over here. And that concludes our color-coded version of our heart diagram. Okay. Now here's the thing. We have to tie this in with some other issues. And one of the other issues that we need to talk about are the heart sounds. Because as blood flows from one part of the heart to the next, we're going to be going through different phases. And the phase that we like to talk about are systole and diastole. Okay, and really I should clarify this. We're talking mostly about ventricular systole and diastole because the atria have their own pattern of systole and diastole. But when we talk about systolic pressure, we're talking about the pressure that's exerted into the arterial system when the ventricles are in their systolic phase. Okay, and so the quick way of understanding this is that systole corresponds to contraction. And when the muscles contract, when the ventricles contract, the contraction of that muscle is going to cause the ejection of blood from the heart into the arterial systems. So this is going to be the ejection phase. That's going to result from the excitation and subsequent contraction of heart muscle. Okay, and after any muscle contracts, after we have a contraction of a muscle, we have to undergo a period of, we call it a refractory period, or a period of rest. Right? During which the muscle is able to prepare for the next contraction. Okay? And this cycle, the cycle of going from contracting to resting, contracting to resting, each time the heart beats, it corresponds to one cycle where both the atria and the ventricles are going to be going through this systole and diastole. Okay? So if your heart is beating 6 times a minute, then we go through each of these cycles once every second. If your heart is beating 120 times per minute, then we're going through 2 systoles and diastoles per second. Okay. Now, during ventricular systole, the ventricles are contracting. This whole portion of the heart in here is squeezing in on the blood, and what's going to happen is that the pressure increase is going to increase here. The flow of blood here is going to stop. Okay, so in other words, we won't have any more flow of blood from the atrium into the ventricle because the pressure in this chamber, in the ventricular chamber, is going to cause that valve to shut. We don't want blood flowing backwards in a heart, and so as the left atrial ventricular valve closes, the only way for the heart to push the blood would be in this direction through the semilunar valves. Okay, and this causes the first of our two heart sounds. Follow the if you follow the description that's there in the lab book, you'll know that we describe the heart sound as a lup dup, or sometimes it's a lub dup. I can't remember what our book actually says. It's only sitting at my feet as I'm giving you this video instruction. But let's say it's LUP. The LUP is corresponding to a change in flow patterns in the heart. Initially we've got blood flowing from the atrium into the ventricle, and we don't have blood flowing from the ventricle into the arterial system. But with ventricular systole, that blood flow changes. This flow is shutting off, this flow is starting up. And it's that change in flow that results in the sound. Okay? Some people think that it's the sound of the atrioventricular valve snapping shut, and that's not the case at all. It's actually more a change in flow in the same way that if you have a sudden change in flow in your plumbing, it results in a pretty loud sound. Okay. Okay, so think of this. In the ejection phase, we get a change in flow, and we get the LUP. And then after the systole is done, basically, when we start this rest or refractory period, the left ventricle is starting to relax. We're no longer exerting pressure on the blood, pushing the blood into the arterial system. The pressure in the arterial system becomes a whole lot greater than it is down here in the ventricles. And so because the pressure is going to tend to push blood in this direction, the semilunar valves snap shut. In other words, we get a sudden stoppage of flow in this direction, which is going to result in this other sound, the dup. Okay, so dup is over here. Lup is in the first part of the cardiac cycle where we've got ventricular systole. All right. What else? We've talked about the heart sounds. We talked about the general flow rates. Talked about systole and diastole. Yeah, I think we're about ready to talk about blood pressure, and and the tool that's used to measure blood pressure, it's got a name. It's called a sphygmomanometer. Sphygmomanometer. It's one of the longest words we have in the lab book. And what the sphygmomanometer does is basically measures the pressure that we have when the pressure up here in the arterial system is at its maximum, and we call that the systolic pressure. The pressure in the arterial system increases during the systole phase, the ejection phase. The pressure in this area increases. And during the diastole phase, the rest period, the pressure in the arterial system kind of gradually, slowly declines. I mean, it slowly declines, but it happens over the course of about a second or less. And during this diastolic period, the blood is basically flowing out to the peripheries. You'll have some blood flowing out to the arms, some flowing to the head, some flowing down to the rest of the body. And so with less blood in the arterial system because it's flowing out to the peripheries, we're going to have a decrease in pressure. And when that pressure reaches its minimum, that's going to be the diastolic pressure. So we record numbers, a number on top and a number on the bottom. The number on top is going to be the systolic pressure. It might be 110. And the diastolic pressure is going to be something below that, and that might be something like 70. So 110 over 70 might be somebody's blood pressure as measured using the sphygmomanometer. Okay? And how does this work? Well, it turns out, well, you're going to find out today because it's going to be one of the things you do in our laboratory. We measure it out here on the arm. So remember, this is the right subclavian artery, right? So if you follow that subclavian artery all the way out, it goes to your right hand. And so maybe here's your upper arm. Here we get to the elbow, and here we get down to your forearm. Eventually goes out to your hands. Right. So the pressure that we have inside the arterial system is going to be the same pressure that we have over here in the brachial artery. Okay. And so what we do is we exert pressure on the brachial artery. We basically put a little cuff here. Cuff. It's actually a cuff on the outside of your arm. It impinges on the brachial artery. Basically, it pushes inward with varying amounts of pressure, and we could tell how much pressure is being exerted on the on this cuff, and that tells you how much pressure is basically being exerted on the brachial artery. Okay, and so if we tighten up that cuff, basically if we put the pressure, if we pump the pressure higher and higher and higher, what happens eventually is that we cut off the flow entirely. You won't have any flow moving across there. So you're going to listen right there, right at the inside surface of your elbow with a stethoscope. Okay, it'll go out to your ears, and you'll say, "Oh, I can't hear anything." That's going to be the point at which we have surpassed the pressure that is there, even at the maximum pressure on the arterial system. So when we have the maximum pressure here, or the systolic pressure, even at that point, we cannot push blood through the sphygmomanometer compressed brachial artery. Okay, and then we start to ease off on the pressure. We basically, kind of let it down a little bit, let it down a little bit at a time. And at a certain point, we're going to get little pulses of blood. Blood is going to be passing through when the systolic pressure is in excess of the pressure we're exerting from the pads. Okay, but during the diastolic phase is during the times in which the blood pressure is not higher than the pressure exerted by the sphygmomanometer cuff. Blood is going to stop. So we'll get this intermediate flow. Psh, 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 something like that. Okay, so the blood flowing, stopping, is what you'll hear with the sphygmomanometer. Okay, and so that's going to continue until we get down to a low pressure. Continue to ease off on the pressure until even when the blood is at its minimum pressure at the diastolic phase, we still have enough pressure there. So we still have enough residual pressure in the arterial system to push blood through the sphygmomanometer compressed brachial artery. At that point, you'll record the diastolic pressure. Okay, and so like if the blood pressure gets read as 110/70, what that means is that we started hearing those sounds. We call them Korsakoff sounds. We start hearing the sounds as we're easing off the pressure. We start hearing the psh, psh. You look down at the pressure meter and it says 110 beats per minute, and you continue to release the pressure. And when we stop hearing those sounds, psh, psh, then you realize that the blood's flowing through the brachial artery continuously, and the pressure that you read at that point will be the diastolic pressure. Okay. The other thing we'll be doing at this point will be measuring our cardiac rate or our heart rate, which we measure in beats per minute. I'm not going to talk about that too much because it's pretty easy. You can detect your pulse either at your wrist or on your neck using your common carotid artery, your carotid arteries, and you can count the number of beats you have in 6 seconds, multiply by 10. You can count the number of beats you have in 10 seconds, multiply by 6. You can count the number of beats you have in 15 seconds, multiply by 4. Many ways of doing this, and we don't need to go through that anymore. All right, but we will be doing these exercises, both measuring your heart rate and your blood pressure before and after exercise, which basically means at some point in our laboratory, you'll be running, you'll be exerting yourself, doing jumping jacks or taking a lap around the 4500 building. Okay, and so as you're doing that, you'll probably want to be wearing some footwear a little bit better than high-heeled shoes. Right, so got that. So sandals, I suppose, would be okay if you're comfortable running on sandals. But I got you. We're not allowed to wear sandals in laboratory because it's open-toed footwear. So wear tennis shoes to this week's laboratory because you will be doing some exercise. All right, that's part one. Part two, what I want to do next is to cover a little bit. We need to talk a little bit about the nature of muscular contraction, because if we look at that heart again, basically we sort of visualize the heart. Here's the heart. We know that we're going to be contracting. This muscle is going to be, we'll have the heart pressing on the ventricular spaces. You've got a ventricular space in here, ventricular space in here, and as the heart is pumping, those ventricular spaces get a lot smaller. And that's going to happen because the walls of the heart are going to thicken up, right? So the walls of the heart thicken up, reducing the volume, and that reduction of volume is going to be causing the blood to flow into the arterioles, okay, arterial system. Okay, okay. Now, hearts, like all muscles, do exactly one thing, which is they shorten, and they can shorten with a significant amount of force, especially if you have many muscle fibers running together. Okay, and so the concept that I need you to have here is the idea that muscle fibers are contracting due to kind of an electrical signal, electrical stimulation, because if a heart fiber, which is normally this long, becomes excited, the result is all these actin and myosin units on the inside shortening up, and that results in a much shorter muscle fiber. It gets shorter and it also gets thicker. Okay, so in other words, as muscle becomes excited, a longer muscle is going to be turning into a shorter, thicker muscle, and after this excitation is done, we need the muscle to return back to its original state of being long and ready to respond to the next excitation phase. Okay, and this is all going to happen in the span of less than a second for people's in people's hearts. Okay, so this contraction and relaxation is what we want to consider, and how does that happen, and how is it related to the electrical signals that we detect using the EKG? Because this is something that we monitor using the changes in the electrical state of our heart muscle. And so it's going to work like this. You've already heard about sodium and potassium pumps. So we know that sodium, Na is the symbol for sodium. Na plus means that we've got a positive charge, so that's the sodium ion. And K is a symbol for potassium, and it also has a positive charge. And in earlier lessons we talked about how we've got on a lot of cells sodium potassium pumps, which have a tendency to push the sodium molecules to the outside. Sodium ions are going to be in higher concentration on the outside. Potassium ions are going to be in higher concentration on the inside, right? And so the other thing that we have, because there's kind of an imbalance of charges. I mean, yeah, it's not like we're going to have an equal number of sodium and potassium. The number of positive charges outside of a typical cell, we're talking about a muscle cell here, is going to be greater than what we have on the inside. So if you look across the membrane of a muscle fiber, a muscle cell, you're going to have a positive charge, a lot of positive charges outside of the membrane. And on the inside of the membrane, you're going to have negative charges, right? So we call this a polarized membrane. This is a polarized membrane because we've got a charge difference, kind of like the polarity that we find in magnets. And this is going to be true across the entire cell. So even on the other side of the fiber, we'll have negative charges on the inside and positive charges on the outside. Right? And what this does, it actually increases the tendency for positive molecules to move in the direction inside the cell. And so what I'm saying here is that during the excitation of heart muscle, what happens is that gates open and allow the sodium ions from outside of the cell are allowed to pour into the cell for a very short duration. And what that does is it effectively reverses the polarity. For a very short instant, we're going to have negative charges outside, positive charges on the inside. The change in this electrical state is going to cause this whole muscle to contract. Okay, so that's a signal that causes the actin and myosin fibers on the inside to shorten up relative to each other, to pull on each other really tightly, and that causes the muscles to contract. And then immediately after the contraction, that influx of sodium ions stops, and we'll start having an export of potassium ions because we already know that there's a lot of potassium ions on the inside. And as the potassium ions are on the inside moving out, we're going to reestablish that original state of having positive charges on the outside relative to negative charges on the inside. We reestablish that membrane polarity, which is going to be taking us back to the status quo ante, the original state of affairs, where we've got positive charges outside, negative charges inside, and this muscle is ready to go to contract again. Okay? This all happens. This depolarization and repolarization takes place in the span of about 200 milliseconds. Okay, so that's 200 thousandths of a second, which basically means you can do about 5 of these per second. And if you do the math real quickly, you'll realize that if we actually did have a cardiac cycle occurring once every 200 milliseconds, that would mean we would have about 1200 beats per minute, which, as it turns out, is about the heart rate of a hummingbird. Uh, Hummingbirds probably have other adaptations allowing their hearts to beat faster than ours, but the consistency is actually pretty reassuring here. Okay. Now, as we're thinking about this, as we're doing our consideration of the EKGs, what's going to happen is that we can detect this type of excitation as as a wave of electrical. We can, because our bodies are made up mostly of water, and water is a really good conductor of electricity. What happens in the heart with the excitation occurring during a heartbeat is detectable at some distance away from the heart. And we'll be setting people up with monitors, with electrical monitors on the wrists and on their ankles, and we'll be using that to detect the presence of these depolarization signals in the heart. The repolarization is another electrical event that occurs in the heart, and it too can be detected at some distance away using our EKGs. Okay, so we'll keep this in mind. We'll talk a little bit more about what's going on with that original picture now. Okay, so as we're looking at this picture right here, you can see the sinoatrial node. Sinoatrial node is also known as the pacemaker of the heart, the natural pacemaker. And it's actually true that we don't need the sinoatrial node in order to make the heart contract. The heart contracts periodically naturally. You can detach the sinoatrial node and the heart will continue to beat. That beating rate can be increased or decreased, and that's kind of like the job of the sinoatrial node. It's called, some call it the SA node, is the thing that's right there at the top of the heart, causing it to initiate the sequence of excitation. You can see that the wave of excitation is passing across the atria and eventually gets to the structure called the bundle of His, which then carries that signal, carries that depolarization signal across from the atria to the ventricles. That wave of excitation is not allowed to pass directly from the atria to the ventricles because we've got a good insulator in between the ventricles and the atria. This is important because when we contract the ventricles, we want that contraction to start from the bottom and push upwards, kind of like a tube of toothpaste, right? We don't want the atria to basically pass that excitation all the way down to the ventricles because then it would basically be pushing blood down to the bottom of the heart. And that's not the right direction. Okay, the bundle of His is going to transmit that excitation down, right down the middle of the heart, right down the ventricular septum through these Purkinje fibers, which transmit the excitation signal all the way down to the very tip, the very the very tip, the pointy point of the heart. And from the point, it's going to be passing that excitation signal is going to be passing upwards, so that we actually have a nice effective ejection and emptying of the heart into the arterial system. Okay, now we'll be moving this picture a little bit outwards now, and I want you to see the EKG that's associated with this, and we're going to be stopping this as well because I want you to see that, oh yeah, when the atria are contracting during this part of the atrial contraction, that part is going to be detected with the first lump in the EKG. We call it the P wave, and that corresponds to the atrial contraction. And then after that signal passes through the bundle of His and the Purkinje fibers, we're going to have the ventricular contraction, which is another really significant. It's a much more significant event relative to the atrial contraction because the ventricles are a much stronger muscle. Okay, and so the next part we see is the QRS complex, this really big zigzaggy thing that we'll see in the middle of each heartbeat as measured on the EKG. Okay? And after the QRS complex, we'll see another wave, another pretty significant bump, which is going to be the T wave. And the T wave corresponds to the next electrical event in the heart, which is the repolarization of the ventricular muscles. Okay? Remember that we're going to have to do that same thing that we described earlier, where after the contraction, after we have that initial depolarization, a repolarization is going to be necessary, and that's going to be detected by the T wave. Kind of visualize all those potassium ions being pushed to the outside again. Okay. Now we're going to be measuring our EKGs. I want everybody to take away a little copy of the EKGs, and we'll be using that to recalculate the heart rate of the person whose EKG is being monitored. And done EKGs, blood pressure, heart rate, how muscle fibers work. And so I think that's it for this video.